My name is Emad Kandil. I'm an endocrine surgeon at Houston Methodist, and thank you everyone for coming. Wanted to take some time that we're going to be talking about a novel technology called microwave ablation of thyroid nodules. And this is going to be a presentation followed by open discussion, and then we're going to be talking about controversial topics later on as well. And so I've been doing radiofrequency ablation, for the past few years, and what got me interested in thermal ablation of thyroid nodules is really the drawbacks of surgery. And as a surgeon, first, with any kind of surgery, you need to have general anesthesia, and there's a prolonged recovery time. While with any kind of thermal ablation, whether it's radiofrequency ablation or microwave ablation, it doesn't require general anesthesia. We can do it under either local anesthesia or conscious sedation, and the recovery time is really minimal, where people can go back to their normal activities the very next day, including the swimming or vacationing. As with the surgery, it resolves limitations. Even if they're going back to work a few days after surgery, there's still restrictions over the next few weeks. And with the other thing is really with the hypocalcemia and the hypoparathyroidism. With a total thyroidectomy, there's up to a 30% risk of hypoparathyroidism or transient hypocalcemia. And in permanent hypoparathyroidism, it's about 3 to 5%. And with any kind of thermal ablation, it's really negligible. It doesn't happen. And that's another huge advantage of thermal ablation. The other thing is with nerve injuries. Obviously, with the injury to the recurrent laryngeal nerve, with thyroidectomy, the risk is anywhere less than 4%. With any kind of thermal ablation, it's less than 2%. So there's a lower risk of having injury there. And then the last thing is really the cosmesis factor in having a scar. At the end of the day, nobody wants to have a scar. And what's most humbling as a surgeon that I had was, we all think as surgeons that the incisions look beautiful. And there's been multiple surveys, patient-driven surveys of satisfaction, that up to 50% of patients are not happy with their incisions after surgery. And this can be ameliorated completely with having an ablation technique. And so I'm really excited to be hosting this topic about microwave ablation and talking about the novel innovation, and introduce Dr. Emad Kandil, who's one of the highest volume ablation specialists in the country.
Thank you for the introduction. So, as Helmi said, both him and myself, for example, we've been doing significant numbers of radiofrequency ablation. And today I'll be discussing with you the reasons that made me consider looking for something different. So after doing 1,000 of radiofrequency ablation, and with good results, there are reasons to consider looking at different technologies. So through this short talk, I will have a case presentation. I will talk about the basics of the technology. I will just go over published experience and some comparison to the radiofrequency ablation. So 3 years ago, I published this multi-institution study with my dear friend and mentor, Dr. Feng Han, who's sitting here, between Tulane and Hopkins, and we published the first experience in the United States in Annals of Surgery with good outcomes. But what we also showed that, similar to what was published before by the Europeans and our Asian colleagues, that very vascular nodules can be significantly resistant to the good outcome with the radiofrequency ablation. This paper was followed by another multi-institution study, again with Raf Tufano and my team and the Stanford team, and we looked at over 600 cases. And again, one of the factors that impacted the volume reduction rate is the increased vascularity in these nodules. So let's go over this case. This is a 75-year-old female who had compressive symptoms related to almost 4 centimeter nodule. The initial biopsy showed follicular neoplasm and she was offered surgery, but then when she came to us, we decided to do the Afirma genetic testing, and the risk of malignancy was less than 4%. So very elderly patient with a benign Afirma testing, I think it's very appropriate to avoid surgery on her. She's not going to die from this. So we discussed the option of the ablation. As you can see here, the nodule, it's extremely vascular nodule. The first radiofrequency ablation, we got a response to 22%, obviously not good enough. And she continued to have compressive symptoms. Yesterday, we saw some data that we presented with the second ablation have much better outcomes, so we offered the second ablation. But let's see here, the first ablation initially 32%, and then went again started to increase to 22%. So we did the second ablation, and again, just the maximum response was 30%. Again, this is not considered a success. This is considered failure of treatment. We usually consider volume reduction rate of less than 50% is a failure of treatment. This is here a summary that I share with my patient, looking at the 3-dimension and the volume, and you can see the maximum response with 30%. So we decided to do the microwave, and 3 months after, as you can see here from the table, was almost like 80% shrinkage in the volume reduction rate afterwards. And I had many cases like this, so I'm not going to go through these cases, but what I want to discuss here is something called the heat sink effect. So the heat delivered by the microwave is really kind of uniform, and it's different from what happened with radiofrequency ablation, where the heat travel down the path of the least resistance and get absorbed with what we call a heat sink effect. So the effect of vascularity of the nodules is significantly less when you use the microwave technology compared to radiofrequency ablation. So I will continue to talk about why microwave can provide an efficient, precise option, but also we treat a lot of patients with cardiac surgical implants and cardiac comorbidities. And if you decide to provide RFA option to patients with pacemakers or ICD, you need to follow certain guidelines, because to my knowledge, there's no FDA approved protocol for any of the RFA probes that we use that we can offer to these patients. So I've done it on a number of patients, but we have to really have good clearance with the cardiologist, good contact with the cardiologist, and we need to make sure that we have the presence of the device manufacturer person to make sure that we can interrogate the device as needed. We consider magnet placement also if something got triggered while using the RFA. So it's just a lot of work, and we have to do these obviously in the OR under cardiac monitoring with anesthesia team. You do not need to put the patient to sleep, but you need to have a good monitoring to do these cases. But if you do offer a microwave ablation, you do not need to do any of this. So it is safe because it's very effective at the lower power input, and it does not have the possible spread of the electricity that the radiofrequency ablation have. Additionally, there is no clearance to use the radiofrequency ablation in, for example, pregnant patients, but you can use the microwave ablation too. So what microwave provide is just basically similar thing to RFA in providing the heat through electrical field with frequencies that can increase from 900 to over 2000 megahertz. And this heat that's generated eventually will lead to coagulation necrosis through the kinetic energy from the microwave technology. So the system again has a generator, a cable with a cooling component, and antenna that you can use. And we do not need to make any skin incision or anything. You can literally just use another needle to introduce the probe. It does have a temperature sensor at the end of the antenna that can be cooled at 0 degrees Celsius, and the diameter of the coagulation zone increases with the power setting, so you can go up on the power. So for example, if you use here the transseismic approach, and you're very close to the dangerous triangle, you start with the low power, and while you are using the moving shot, it's very similar to the radiofrequency ablation. If I'm inside the nodule, I would increase my power to provide more energy, and I will touch base on this later. I do this anyway for radiofrequency or for microwave, Dr. Feng will go over the details of the procedure, but I just want to discuss the issue of the power here that we use. And you can just, again, continue using your moving shot technique. So this is here a large single center cohort study that looked at almost 1,200 thyroid nodules, and the reported volume reduction rate at 12 months was over 92%, with no effect in the thyroid function test in these patients. Again, the study from China. Most of these procedures and most of the data is from China, and it's amazing when I went and visited there, many of these providers who've been using radiofrequency ablation for many years are completely switching. And I'm not completely switching, we can talk about this later, but it's interesting that, again, many other studies showed a volume reduction rate for over 90% at 12 months. When you compare it though for radiofrequency ablation in a lab setting, the results are very interesting. So this is an interesting study with ex vivo bovine liver tissue, where they did an ablation with radiofrequency and microwave and did CT images and looked at the outcomes afterwards, what happened to these tumors after the ablation. And you can see on the top is the radiofrequency ablation, and the red and the green and blue are all from microwave. The difference is the increase in power from 50 to 75 to 100 microwave. So the more power you place in the nodule, the more volume reduction rate you obtain by doing the ablation. One thing here to understand that there is a reason. If you talk to any interventional radiologist, we have Dr. Feng from China who's an interventional radiologist today, but in the US, radiofrequency ablation was a technology that was used to treat liver metastases or liver lesions, and this is an absolute indication for the use of liver lesions in today's practice in US. And they completely moved to microwave or cryoablation because it's just faster, provide more energy, and has much better outcome. And if you ask any interventional radiologist, they will tell you because of the heat sink effect that I mentioned earlier. But I like this study because it just basically shows very clear data that's just very well studied on the difference in the microwave compared to radiofrequency ablation in the lab setting. So again, with just a higher power level, and we showed similar data combined with Hopkins again in relation to the radiofrequency ablation. The complications, again, this was very nice randomized controlled clinical trial from China, and looked at swollen nodules, and the complication rate, they looked at RFA versus microwave, were very similar. So most of us here know the risk of complications is extremely low, and it can be extremely dangerous complications sometimes, but I'm not here to go over the list, but it's very similar to the radiofrequency ablation. The topic of PTMC and micropapillary carcinoma is a very interesting topic. I like this study looking at the microwave outcomes in patients with almost like 1,200 patients, and the follow-up was on average 34 months. There were only 10 patients that developed central lymph node metastases, which we all know that this is maybe clinically insignificant, and in their experience, 1% has hoarseness of voice and more recovered within 6 months. This is another paper that I really like, because we see in our experience when I treated at least over 100 patients with papillary thyroid cancer, and at least 2/3 of them will disappear, or the repeat biopsy will show no evidence of residual disease. But this study looked at 10 patients with 11 PTMC who underwent ablation, and they took these 10 patients to surgery. So they have the surgical specimen, and there was no residual disease found in the ablated area. Having said that, they routinely do in these institutions in Asia, as we know, a central dissection, and they found in 3 patients out of these 10 patients central lymph node metastases. As we all know, if you want to start a fight in an endocrine surgery bar, you talk about prophylactic central lymph node dissection. What's the value of it? Because it's a beautiful thing that as a surgeon we enjoy. It's just a fun for a surgeon to perform a central dissection. But what's the value compared to the possible complications? So I will end with this study here with microwave in pediatric population, looking at a small number of patients, 25 pediatric patients, and again the volume reduction rate were up to 85%, and almost 18% of these patients, the nodules completely disappeared at the end of the visit. So in conclusion, I can tell you this: microwave is definitely a very novel, safe option in treating patients with benign nodules and also possibly malignant nodules in adult and pediatric population. I think there are more studies needs to be done to compare the outcomes between radiofrequency ablation and microwave, and possibly other modalities that are coming up. There is definitely very happy patients or excellent outcome that we obtain by providing these options. But I believe that there are possible indication for certain scenarios to use different modalities in different patients. And I thank you again for listening. But you know, one final thing, I like this book, Ego is the Enemy. You know, as a surgeon, we always believe that we can do good operation, very low risk of complications, and we decided that most of us tried radiofrequency. Now with microwave, you can say, well, I've been doing radiofrequency, I can do thermal, but there is other things that you can consider. I'm not saying that you should completely ignore what you've been doing, but I tell you, there is definitely an answer, and I'm not saying that this is the one definitive answer, but there is definitely other modalities that can provide help for certain other patients that might not benefit from one technology and benefit from the other technology. Thanks again.
So I'd like to introduce Dr. Fan, who's one of the highest volume interventional radiologists doing microwave ablation in China, and give us his insights and his experience.
Good morning, everyone. It's my pleasure to be here. Let me introduce myself. I'm Feng Han from Guangzhou, China, the Yat-sen University Cancer Center. Actually, I'm a radiologist. In our hospital, we did a lot microwave and RFA, most microwave ablation of the thyroid. Today, I stand here to share some of my experience about what we have did about the microwave. Maybe in US, not too much doctors have tried the microwave, so maybe some basically, but I think it's important for us to understand how the microwave works, how can we counter the energy. I think the energy inside the nodule is very important for all of us. Okay, let's see. Traditional, we usually use fixed ablation for the liver or other deep organs. Just put the needle there and ablate for several minutes. With the time consuming, the area becomes bigger and bigger. But the thyroid is different from this. Surrounding the nodule, there are much more important constructions, such as the nerves, the vessels. So we must move the needle to make the ablation area fit the nodule. So that's why we use a moving short technique. So I will introduce in 4 parts. First, how to make a dot. Use the dot, make a very small dot. Then how to move the needle in a straight line to make a line ablation. Then you through several lines make a whole level complete ablation. Finally, we can by several levels make a whole nodule ablation. In the last we have discussed the hydrate section. First, at the beginning, about 10 years ago, we got some swine thyroid and tried how the microwave works. let's say, in different power and different times. With the time and the power change, the area changed. Most this is the 30 watts, for 35 watts and 40 watts we use. With the power change increase and the time decrease, the area becomes larger and larger. But mostly we can see it's about 12 millimeter to 17 millimeter pulse, 5 millimeter and 8 millimeter. So it's very not a very big area. So I think it's very stable sometimes. So with this fixed ablation, we can treat some cases, small cases, especially for the PTMC, the papillary thyroid micro carcinoma. This patient is a very small carcinoma, PTMC, about 6 times 5 times 4 millimeter, and the situation is very good. So it's a safe place and a small one. It's suitable for the microwave ablation. And we also did the biopsy. We confirmed it's a papillary carcinoma. Maybe different from other center or other doctors, we treat this patient not to put the needle inside the center of the tumor. We just surrounding the tumor. Usually we have four times up, behind, before, and the lower place. We don't touch the tumor. After the 4 times of ablation, we use the 30 watts, and every time we last 30 seconds. We can see in this screen, there are the 4 bright points. Is where we place the needle there. Yes, but it is difficult to determine, to find and to confirm how large the whole area is. So usually, and I'm an ultrasound doctor, so we use the contrast agent to confirm how big the area is. So we do the contrast ultrasound. We can see this whole area has a black hole. That means no blood inside this area. Which means it's okay. So it's large enough to cover the whole nodule, the small PTMC. So I think it's good. The second part is about how to move in a straight line. For some newcomers all ready to do the microwave or RTA, it's really, I think it's a really common problem. Usually we move the needle at the rest in the center, so like this. Actually, most of the time the needle moves in a curved line, not a straight line. So we should try ourselves to move the needle both with the wrist move and the fingers. Like this. To make sure the needle moves in a straight line. I think it's important. Only in moving the straight line, we can make the level in a flat level. So if we don't, and some newcomers, new doctors do the microwave, we can see not a flat level, it's like a dome. So when we skin and the ultrasound, we can see the surrounding area are not treated. So we need to cost some time to treat the surrounding area. So it will cost of a lot of time. This is what we work. We use the moving shot technique. You can see we usually don't stop the needle, just moving and stop the needle continuously in a straight line. We can see the bubbling, the nodule become bright. That means this area is okay. So, if we can monitor the needle, especially the needle head very clearly and continually, I think it will be very safety and efficiency. This patient is next we're talking about how to cover the whole level. This patient with a very with a nodule in his right label. Before the ablation, we also have elastography exam. In this picture, the blue one means it's soft, the red one means it's hard. This is the ablation. After the ablation, we can see it's become white. It just means this place become very tough. We punch the needle through this direction. So in this direction, you find it's the most right place. That means the energy in this place is much more than we need. So we should do the ablation isogens. We don't need to, every time we don't need to pull the needle back to the surface. Maybe every 3 or 2 or 3 traces we back to the surface. Back to the surface the first time. The second time we touch the bottom and go to the bottom, that's okay. That can save our time and the energy is enough, I think. Sometimes I suggest, place the needle head at the border for about 2 seconds to make sure this place has enough energy. After the 1 month, we can see the VRR is about 43%. And the ultrasound doctor maybe from these 2 pictures can see what we had did 1 month ago. Let me show how it happened. This is the chest. The left picture it's the chest. Every time the needle move in these directions and the chest like this. In the right picture, we can see this is the plan, the label. Every level almost parallel. Okay. Finally, I'm talking about the hydrodissection. Hydrodissection is very important for the ablation. It can separate dangerous or important organ or structures and make our ablation much more safety. Usually we have different ways to inject the liquid. Most of us use the saline. We can from the side to separate the vagal nerve, the vessels, and tilt to the back of the nodule and the RNL. You can also from the front, inside or outside, both to separate from the superficial muscles or the skin, especially for some very, very thin person. We can protect the skin. We also can use this way from the internal, inject directly surrounding the RNL, separate the thyroid away from the trachea. This is what we did. You can see we can in different directions separate them. This is the internal, separate the thyroid away from the trachea. You can see we can get some liquid there. They are separated as you can see. But when we use the hydrodissection technique, we will find one problem. The liquid disappears very fast. So we need to continually inject the liquid. So it costs time and it costs pressure. As we all know, this is the needle of the microwave. It sends the energy from the top to the backwards, not forward, backward. So it's very safe in the almost not beyond the tips. So even in our study, even with 40 volts about 2 minutes, the beyond the needle tip is only about 2 millimeters. So it's a very short distance. So I think the most safe place is beyond the needle head. I think it's the most safe place. So now we seldom use the hydrodissection. especially even when it's the nodules near the triangle area. I can show this footage. You can see when we meet this place, we just place the needle head about 2 millimeters away from the border, and hit and move, and very soon we can finish the procedure. Almost every case we perform the contrast agents ultrasound. We can make sure the whole nodule are treated very well. This is another one. It's almost 5 millimeters, also very near to the triangle area. We did the same thing. We don't need to do the hybrid dissection. And after the chemotherapy, we can confirm there is no active place inside the nodule. And 1 month later, the ARR is about 40%. So we also summed the complications of in our department. As we find there are difference whether you use the hybrid dissection or non-hybrid dissection. I think it's when you did enough cases, have enough experience or familiar to the energy, I suggest you can try not to use the hybrid dissection to save your time. I think so. Okay, finally, I think the microwave is faster and stable and predictable, so we can manage the energy very easier to help us to do the procedure. Thank you.